So this was funded by the Robert Wood Johnson Foundation from 2009 to 2013, and it was part of their Healthy Kids, Healthy Communities initiative. There were 49 communities across the United States that were selected to be Healthy Kids, Healthy Communities. And Cuba, without question, was selected because of its affiliation with Viva Step into Cuba, that the capacity was there in order to implement this type of a program. And the team members rotated a lot in the period. I actually didn't come on as PI for that project until 2011, but by the end, the team members were myself, Alejandro, who you met this morning, who's up in Cuba, and then Francesca worked on it for a little bit of her time last year, and then Leslie and Alicia. And so briefly, the food access strategies that we worked on was establishing a farmer's market in Cuba, also working with the already existing Cuba community garden and providing technical assistance and some supports for that. Also healthy vending, which we worked on at the Sandoval County Fairgrounds, which is in Cuba is the fairgrounds for the entire county. So the county fair is a very big deal, and it's there. And so we worked on having healthier options for the vendors, and then also pricing structure changes, so selling water for less than soda, that type of thing. And then also backyard gardening in some of the outlying native communities. And that really came out of, we were initially looking at potentially working on a mobile market and something like that. And they really said, well, hang on, actually what we want to focus on, distance, et cetera, is supporting backyard gardening efforts. So we worked on those types of initiatives. These are some of the kids. The other thing that we did was we had a graphic designer at the time, Mary, who developed these beautiful, along with the community, with our community partners, developed these beautiful logos that the market and community garden can continue to use. So it helped them with their branding efforts. And then the places to be physically active, and this was much more in strong partnership with Viva, Step into Cuba. So working together on sidewalk improvements, also doing some pedestrian mapping and improvements to the park. And this is where we partnered with a planning student at the time and it was his project, his student project was to help to develop this plan and develop these maps and work with the community on what they wanted. And so we had this it's hard to tell the scale, the fire extinguisher maybe helps. But so we had this panel display traveled around town, and there was a common box, and so people could provide input. So it was at the school and at the post office and at the public health office. It was all over, at the water utility, everywhere, so that we could be pretty sure to get any input that we could possibly get from there. And these were the partners for Healthy Kids, Healthy Cuba, some of them. And so what I have for, at least for our CDC friends, I have a couple of handouts to provide to you. Also, the evaluation for this, we did some evaluation internally, but Transtria out of St. Louis did the external evaluation for all of Healthy Kids, Healthy Communities. So there's a case report that I'm going to hand to you in a second. And that is also informative for understanding the context of Cuba and understanding the work that's happening there now. And what was nice about Healthy Kids, Healthy Cuba, so Viva and Step into Cuba, there was no focus on any kind of food or nutrition. And so, and that was sort of a role that Healthy Kids, Healthy Cuba played, where it worked on the food environment. And then what's nice is that we've been able to further include that into the YouTube, which you'll hear about later this afternoon. And then what stemmed out of Healthy Kids, Healthy Cuba, one of the many things that stemmed out of it, but for us as a project, is a small project funded by Conalma Health Foundation, which is a local foundation here. And this is just me and Leslie working on this project. But one of the things that we were working on for the farmers market in Cuba was getting them to accept federal nutrition assistance benefits. So that's SNAP and WIC and senior farmers market nutrition benefits. And New Mexico has very high rates of food insecurity. Farmers markets are really critical access points for a lot of folks, particularly in rural areas, for vegetable consumption and fresh fruit vegetable consumption. And so these three different programs, they have different mechanisms for application and different mechanisms for redemption of the market. And what we really wanted to do was understand what the barriers and facilitators were across the state. What we had found in our work with Healthy Kids, the application for SNAP in particular was terribly burdensome. It was it's somewhat perceived as an invasive application. So you have, basically, if you are a farmer's market manager, it's the same application as if you're a grocery store. So they need your social security number, which a lot of people don't want to give them. Hand that over. And because New Mexico is a community property state, if you're married, then you also need to provide the social security number of your spouse. So trying to get that just in and of itself was a challenge in order to get SNAP in. There was limited technical assistance from USDA. At one point I called and they said, and I asked all my questions, and she said, oh, well, that can be answered by your local rep. I said, well, great, can you give me that number? No, we can't give that out. So, and then also you would have to provide a new application as you had a new manager, and that can happen very, very frequently because for the large part, these are volunteer positions. We estimated between Alejandro and myself, I believe we estimated that it took us about 30 hours of our time just to navigate the SNAP application process on behalf of the market. So we were paid, right, under Healthy Kids Healthy Cuba to do that work, but what is the incentive for a volunteer market manager who probably has a whole other job or two that they get paid to do, and then this is on a volunteer capacity. And then the redemption process for WIC and the Senior Farmers Market Nutrition Program can be somewhat troublesome. At one point, the stamp on it was crooked, and so the bank wouldn't accept it, or there's also a limited time frame. And so the vouchers could be expired, and then a farmer would go to cash them in, and they'd say, sorry, this is expired, and they weren't getting it back. So working through what some of those challenges are, because oftentimes there may not be a huge economic benefit, and this is something that in urban areas and more sort of populated farmers markets, they can bring in a lot from SNAP funding. But SNAP isn't necessarily, accepting SNAP isn't necessarily going to mean a huge increase in dollars for small markets. But if part of the role of that market and the mission of that market is to provide access for the community, which it was in the case of the Cuba Farmers Market, so we can kind of make that argument like, okay, but let's persevere because this is part of our mission. So then that can make sense. But for markets who aren't seeing an economic benefit, they don't have that really as part of their mission and their cause, then it's a little bit of a tougher sell. And so right now, there's less than half of New Mexico farmers markets accept SNAP benefits, about 70% accept WIC and Senior Farmers Market for that. So we've modified, the USDA did a farmers market manager survey, so we've modified that. We'll be following up with focus groups and some interviews, and then by the end of this year, we should have policy recommendations for those who are more at local, state, and federal levels, and then also technical assistance recommendations. And that's the token system that the farmers markets use in our state, where you cash in your EBT card at the front, and then you get your tokens, and then you cash them. Okay, and then now I'm going to roll into we have 3 SNAP-Ed projects. I'm just going to present on one of them. But we have 3 the PRC has 3 projects under our contract for SNAP-Ed, and this is funded through the New Mexico Human Services Department, but that is from USDA. One of the exciting things that we are anticipating knowing the details of, we don't know the details right now, but we do know that there's going to be much increased collaboration. There really isn't any collaboration with Department of Health with SNAP-Ed in our state right now. But this, in fiscal year 16, that this is going to come into play. We haven't received the details about that. We're part of the USDA Southwest region, and Glenda and Teresa and I, we each are PIs on the 3 projects that we have. And so we were invited in April to present at the Southwest region USDA directors meeting on all 3 of our projects, because they really see that what we're doing at PRC for these 3 projects is really a best practice on direct programming, the social marketing, and evaluation, which I can talk about. One of the things that's really exciting for us, that as we've been part of SNAP-Ed and SNAP-Ed implementing agency, the evolution that has gone from, and I'm not sure how familiar everyone in the room is with this, but where it has been sort of historically really focused on individual education and direct education with small groups, and where now they're really expanding, number one, into requiring evidence-based approaches, which has caused some confusion for some implementers who this is not familiar territory for them. And then much more of a public health approach. As we look through the SNAP-Ed guidance changes every year, and as we look through it now, it reads like a public health document, and it definitely didn't 4 years ago. They have implemented the social ecological model, and this is much credit for that can also come from the Dietary Guidelines for Americans having incorporated the social ecological model in the last version of the Dietary Guidelines, which was the first. And they have gone from, when we first started our project, Chili Plus, we couldn't even do the environmental pieces, and that was just in 2011. So we've gone from where you couldn't do policy and environmental work to, you might want to do it. Maybe we'll see tested, sure. And then now it's actually required. So just in this very short time frame, SNAP-Ed has changed, and it's really the largest access point for nutrition education in the United States. They've also now incorporated the reading framework, which is really new and interesting. So that's sort of overall. So Chili Plus, the Child Health Initiative for Lifelong Eating and Exercise Plus. So this was born entirely out of Dr. Davis's Chili project, and that was funded by NIH. And that was a randomized controlled trial in 16 tribal and non-tribal Head Start centers. So the components of this project, so we have a food service component where we work with the food service staff in providing specific fruits and vegetables. There's also a classroom. The biggest piece of it really is the classroom component where children are, we have a curriculum which is actually over on that table. The Chili curriculum is there, so you can take a look at it. And all around increasing exposure to new fruits and vegetables.
Also on the CDC website.
Okay. And we have a grocery store component where the labels are in the grocery store with the logo that direct families to those healthier choices. We have family events that incorporate these nutrition, skill building activities and physical activities. There's a healthcare provider component. We've expanded this in Chili Plus to also include WIC providers where they are mirroring the same messages. And then we have materials that go home every week to families. So there's nutrition newsletters, physical activity, and there's physical activity in the school day. We try to increase structured physical activity by at least 30 minutes every day. And then this is new for Chili Plus from Chili, and this is where we partnered up with Glenda's project, and we're utilizing the social marketing materials that they developed, which she will talk about more, so that people are seeing them in the Head Start, at the healthcare provider, and in the grocery store. So this is our team. So myself, Francesca is our project coordinator. Phil Cordova is our health educator. He has more of a background in exercise science. That's his bachelor's degree, is in exercise science. And then Sally Lopez, she's a health educator as well. She's a former Head Start teacher. That was one of the, as we've talked about, where in our multidisciplinary team, what are we missing? And we realized we were really missing an early childhood educator. And so we brought her on, and it's been outstanding to have her because she's been really helpful in helping us sort of map out where things fit within the early learning framework for Head Start. Felipe with TV Burning That, Glenda helps us out with all kinds of things, and Leslie and Alicia help us as well. I'm ready to talk about this. And so in fall of 2011, we were funded as SNAP-Ed. We enhanced the changes really that we made. We enhanced the family component and focused just on SNAP-eligible families. Head Start automatically counts for that under the waiver. And then, as I kind of mentioned, we gradually reintroduced those policy systems and environmental approaches since it became allowed in the federal fiscal year 13. And we kind of always tease USDA about that. Like, you could have just let us do what we already were doing in the beginning instead of having to take these pieces apart and then build them back in again. So the objectives of this project, basically, we want to see more fruit, vegetable, whole grain, more fruit vegetable consumption and more water consumption, and then a switch from refined grains to whole grains, and from higher fat dairy to low fat dairy. And then we really focus specifically on fewer sugar-sweetened beverages, also portion size, and then at least 30 minutes every day engaged in moderate to vigorous physical activity, and then no more than 2 hours a day watching TV and playing video and computer games. Here is where we are, so just to give you a sense, these blue X's are kind of our real major urban areas. So here we are in Albuquerque and then Santa Fe and Las Cruces. And so the red sites, the red balloons, we're in 25 head starts right now. So the red balloons are the sites that we've been in just since this school year now. And then the blue ones are the ones that we've been in since 2011.
So are you hoping to see that the children have picked up in other Head Start locations?
Are they going to?
Are you hoping?
We are. We'll see what we're supposed to be learning what this change is for fiscal year 16 coming up.
Okay.
But we absolutely are, and that's only limited by funding. We know Bravo Nation is approached us about wanting to do it out there, so I think we'll definitely be expanding. We'd love to take it statewide, and that's ultimately the goal, and that's really the goal of Human Services Department. They'd really like to see it go statewide too. So I think that's going to be kind of part of how we're going to be working with Department of Health. And as we know more, I'm happy to share that.
Okay, thank you.
So we have been doing social marketing for a few years now, and the way that this collaboration started with SNAP-Ed, it's because the state agency, the Human Services Department, wanted to use the core nutrition messages created by the Food Nutrition Service as USDA, and they realized they were not in Spanish, and we needed them in Spanish. But they didn't want just the translation. They actually wanted to use the social marketing approach. So all of the basis of the formative research, getting to know the community. So they approached the PRC and asked Dr. Sally Davis, can you do social marketing for us? And that's how the funding started with SNAP-Ed. So we started conducting some focus groups in urban and rural areas here in New Mexico in Spanish. Then a couple of us went to the training academy at the University of South Florida, the one that is led by the PRC in Florida. And we did the training academy, the conference, we came back, we continued formative research, conducted focus groups, developed some of the first messages in Spanish and test those. Then last year, the coordinator of the SNAP-Ed program at Human Services Department, she wanted to go and get more training on social marketing. Because the funders, what they want is they want other implemented agencies. There's about 6 implemented agencies here in New Mexico for SNAP-Ed. And they want all of them to do social marketing. So she went down, she got the training. We actually presented at the International Social Marketing Conference our project here. And when she was there, she said, there's a need. We need to bring all this information back to New Mexico. So when we came back, I gave a noon conference on social marketing. And a lot of people, not only from the university, but other places came, Department of Health, Indian Health Services. So we realized there was a need in the community for social marketing. So Dr. Sally Davis worked really hard on bringing Carol Bryant to do a 2-day training here where we invited the university again, but it was open. Well, it wasn't. We were limited for 30 spots, which unfortunately we had to limit to some people. But she gave a big noon conference, and the idea was to collaborate with the PRC, the Florida PRC, for us to be able to support the efforts of social marketing here in New Mexico. It has been great. Our funders also wanted me to do a certificate in social marketing that Florida PRC offers that also. So I'm almost done with that. The members for the team, for the social marketing team, are myself and Jennifer is the research coordinator, Felipe, Darlene, and Danielle, and her name, The campaign that we're currently implementing is called the It's Smart to Play Hard campaign. And the way we came with this is after all the formative research and conducting focus groups, we tested different messages with children. This is directed for children ages 8 to 10 that speak Spanish and their families. And we are almost finished our pilot testing of this campaign in the south part of Santa Fe, which is a very interesting area. It's also called Little Chihuahua by some because of the amount of recent immigration from Mexico. So there's a lot of Spanish, there's a lot of disparities, health disparities, very interesting group. And we are conducting this It's Smart to Play Hard campaign. When we tested the messages, the FNS for nutrition messages, the children chose this message, It's Smart to Play Hard, eat fruits and vegetables at meals and snacks as their favorite one. And when we asked them why, they said, we like to play. So reinforcing the social marketing principles that children will change their behavior, not necessarily because of our reasons of being healthier, but because of their own reasons of playing hard and having fun. We developed this 12-week campaign with this passport. So there's a 12-week passport that we invite them to 12 weeks of fun and adventure. And each week they have to do a fun activity, a learning fun activity, and then they have to do a recipe. And they have stickers at the end of the passport, and they can put a sticker and on each day for each portion of fruit and vegetable that they eat. So they're accountable of what they're doing. And the idea is that they cook the recipe at home with their parents, and then at the end they get the parent has to sign it, and then they take it to school, and their teacher puts a stamp, and It's Smart to Play Hard stamp. So the more stamps that they have at the end, the more fun they will have on a big celebration that we promised them. We are developing this campaign for one of the implemented agencies, another SNAP-Ed implemented agency, which is a program called Cooking with Kids, which is a program that cooks in the classroom with the kids. And it's very successful. The kids love it, the kids really like it, and they learn to enjoy cooking. But when we asked the school, the kids, the parents, and even the program, or the staff of the program, they said we're missing something like that connection between the program and the home. So teachers feel they're doing a great job at the school, but it's not going home. The goal of the social marketing campaign was to take this great work home so that the kids will teach their parents how to cook and enjoy it with them. And that was the idea for them to bring it to the classroom. So we developed a strong promotional piece also to help them and to support them. So there were pictures at the grocery store, at the bus stops. They had this reinforcement with the messages, with the chosen messages for parents to remember what they were supposed to do, and children to remind their parents, help me with my passport with this challenge that I have. And at the end, we invited them to the big event. Actually, last week was week 12, so we were celebrating at the 3 different schools our events. And the idea is they had to bring their passports, so they all brought their passports and had fun. That was the goal. So we brought the soccer team from the university. So all the kids got to play soccer with the Lobos, which is a big deal. They're really, really good. And the fire department was there, the state police was there with their radar guns to measure how fast kids were running. And what else did we do? Parachute and sack race. They had fun, but that connection of eating fruits and vegetables and doing this adventure with their parents and the connection of fun was the goal. And I think in that term we succeeded. They had fun, but now the evaluation piece is what we're looking for and see if the campaign did change behavior. The goal of social marketing, again, is to change behavior. So did families increase their consumption of fruits and vegetables after this campaign? That's what Teresa is going to explain how she's going to find out.
So about 2 years ago, the folks with HSD contacted us again and said, okay, now we've got these 2 programs going, as well as another 4 programs around the state, but they didn't really have any systematic way to evaluate them. And so they asked if we would come in and help them to figure out how to do that. And so Emily and I are working on the evaluation piece. And really, we're looking to see, are they increasing their, kids increasing their consumption of fruits and vegetables? And they're SNAP eligible, so it doesn't necessarily mean that everybody who's participating in this is receiving SNAP benefits, but they're SNAP eligible communities. And then looking at specifically this year at Glenda's social marketing project, which is talking about adding in Santa Fe, and then conducting a pilot test of an environmental scan. We have one new implementing agency that works with a couple tribal communities in the town of Espanola that are adding an after-school program for kids, the CATCH program, and they wanted to see how that's working. So these are the different programs we're working with. ICANN is with NMSU, the State Land Grant University. Kids Cook is here in Albuquerque Public Schools. Cooking with Kids is in Santa Fe. And Chili Plus you heard about from Patty. And then there's a variant of Cooking with Kids that they're using, the Las Cruces Public Schools is using, and that's in southern New Mexico. And then the CATCH program that they're using with a couple tribal communities. And so I built on the map that Patty had. So those little upside down raindrops are the Chili Plus communities, and then you can see where the others are located in the state. So what we did last year was we just wanted to kind of pilot test our materials and to see what we would get back from communities. And so we got a 38% response rate. This is sending a survey home in kids' backpacks to fill out with their parents at home about their eating behaviors over that weekend. Their fruit servings, 1.9, is fairly similar to what data are for fruit consumption, but the vegetable consumption was really high. We ended up, I think that it was an artifact of the way the question was written and that parents weren't understanding it. So we revised it before we sent out the survey for this actual year. They did report, though, increases in buying fruits and vegetables, increases in children being willing to try new foods after participating in the programs, that the environment at home, that they did provide fruits and vegetables for the kids. But a couple of the more negative things is they did have, almost always had whole milk instead of skim or 1% milk. They would have whole milk or 2% milk in the homes. And then there were data on chips and pizzas and that kind of stuff, but I didn't put it all in here. And then they are receiving and using the recipes they're getting, and actually when asked what would make the program better, they said having more events for the parents and more recipes, more ideas of what they could actually do, skills for them at home. So the current status of this project is we are doing this academic year. We did our pre-testing in the fall, and those data have been entered. And the post-test is going on right now, and so we'll be analyzing those data over the summer to look and see what changes we see over the academic year. The component with social marketing this piece was added in, so it's the same survey they're taking in those communities as the other communities were, but we've added in questions that are specifically related to the campaign messages to see if they've either seeing those and if they're recognizing those messages, and then also looking at some of the behaviors around, are they providing more fruits and vegetables as snacks for the children, for example. And then we're also working to look at how we can create a system-wide thing. So there's several other agencies locally as well as nationally that we're working with on an evaluation plan that's being developed nationally. And then also looking for identifying the gaps and challenges, and then being able to share the success stories that are happening. Just for example, one of the things that was brought up was that we have 7 implementing agencies for SNAP-Ed in New Mexico, and a lot of people are familiar with the names like Chili Plus or Cooking with Kids, but they don't realize that they're SNAP-Ed agencies. And so they're trying to bring up more of a awareness and branding around the whole issue that all of these fit into SNAP-Ed and SNAP-Ed funding. Then rolling right into my next project, the REACH project, and I'm so lonely up here, but starting next Monday, and then my son will be here again. So the REACH grants were funded last fall by CDC, and Bernalillo County was lucky to get one of those here. They're primarily working with urban tribal community, urban Indians, and working with the Hispanic community in the South Valley of Bernalillo County, which is one of our more under-resourced areas. So our objectives with the project, they're looking to, and they have very specific objectives, like that's the number of people who live in the South Valley, you know, in the International District, that they're trying to make those environmental changes, though. The same kinds of things we're doing with our project in our Viva project in Cuba, they're working on trying to do in the South Valley to provide opportunities for people to get physical activity. They're also looking at healthy foods and vegetables through use of a mobile market that will take fresh fruits and vegetables to these low-income communities. And then they're also working on something that we don't do a lot, maybe Rob does in his area, but looking at increasing referrals, physician referrals for healthier behaviors. And so those are the three objectives of the project. Here's some of our partners on that one. Presbyterian is actually the awardee for the fund, and that's a nonprofit hospital here in Albuquerque. It was written together with the Community Health Council, and I don't know if we've explained yet. I know I told you that New Mexico doesn't have county health departments, but each county does have a health council, but it's volunteer. They get like $5,000 a year. But basically to look at what are the issues in their county and what are the issues they want to be working on there. And we are partnering with them on our Viva initiative, Viva 2. We're working with First Nations and First Choice, which provide health care. Those are health clinics, and so we're trying to get them to refer for chronic disease self-management programs. And then Farm to Table and the Agricultura Network are the food providers for the mobile vending program. And then Place Matters and the Community Data Collaborative is what Andrea was talking about earlier when he was doing the maps. They're the ones who put all those together, and so they're going to be working with us on looking at some of the data that are coming out of this as we go through the 3-year project. The Department of Health is there working with us, and also the Mid-Region Council of Governments, which is our planning committee. So when we're talking about we need to change to make walking, so different from Cuba, on Central Avenue here, we have sidewalks. It's just not safe to walk there. And so they're looking at how can we make the environment that exists safer. A lot of those people don't have vehicles, so they are walking. They're just walking in unsafe places. And so these are the areas we're talking about. This down here is, sorry, I'm not good with anything. Down here is the South Valley area, and there's the International District, and we're right in here right now. So our role is we're going to be evaluating the actual use of the mobile market. So they're going to have little like debit card things that they get some money on. They're going to register for the debit card, so we'll have their name and age and ethnicity and race. And then they'll be using those cards so we can track their purchasing with that. The policy systems and environmental change, we'll be looking at, they've done several different walkability reports and made recommendations for things that need to be improved for safety of walking. And so we're going to be looking at those to see if those improvements change over the time while we're trying to build capacity and skills among people in the communities to advocate for urban land use changes. And then we're going to be working to evaluate the healthcare provider use of the referral system. Are people getting referred to the chronic disease self-management programs, and then are they showing up and taking part in those? So that one we just got our contract a month and a half ago, although we've been working on it for about a year now. We went for a training in Atlanta a few weeks ago, and we've met with all of the different community partners. The evaluation plan has gone in, and we're waiting for feedback on that. And then we'll be tracking through purchase data, through environmental assessments, and through data abstraction sheets, what comes out of those 3 components of the project. And that's it for me. Leona's going to talk next. This is another project that I thought you might get tired of hearing from me all day. So Leona's going to talk about our 2 sexual assault prevention programs.
Okay, make sure I use this correctly. Yeah, so we have 2 projects, sexual violence prevention and statewide coordination, and the UNM PRC Sexual Violence Prevention Technical Assistance Project, which is too much to say, so we just call it the SVP project collectively. It's Teresa as the PI, it's Dr. Julia Hess, who has worked with us on qualitative research, and then Samantha Bear, our student that is leaving this week, which is why we look a little weepy. Okay, so we have a lot of partners on this project. Our main partners is the Department of Health and the Statewide Coalition of Sexual Assault Programs, and then our 7 rape crisis centers. And you can see that we have a huge state, and we have only 7 centers throughout the state. So, for instance, oops, sorry about that. Portales, I always like to point this out, on the east side of the state, their coverage area is actually 22,000 miles, and their staff is like 3 people. So these centers need a lot of assistance. They do crisis management, crisis counseling, sexual assault services, and a lot of advocacy. And then what we do is support them in their primary prevention efforts. And they're all kind of at different levels in how they understand primary prevention and what they're implementing. But that's really how we work with them. And then through them, we have access to other community partners, like they work within their school systems a lot. They work with their local BB shelters and other nonprofits. We work with Indian Health Service, UNM's Women's Resource Center, the Transgender Resource Center of New Mexico, Human Services Department, Fierce Pride, which is LGBTQ advocacy, and then through our partnerships, we have access to people that work in the disability community. And I'll talk a little bit more about how those partners work with us on our individual projects. So the Sexual Violence Prevention Statewide Coordination Project is actually funded through our state Sexual Assault Coalition, and they have funded us to do technical assistance around primary prevention at 4 of the 7 centers. And so that technical assistance includes making sure they have information about best practices, and there's not a lot of science behind best practices for sexual violence prevention, so we really try to also focus on promising practices. We like to give them reports, and if any guidance documents come out from the CDC, we maintain a listserv that they're all a part of. We do a newsletter, and then specifically we do organizational level technical assistance, which includes 1 site visit a year, and then a lot of phone contact and email contact with each of the centers, talking about their primary prevention programming and how to make it better, how to really serve their community. We also provide coordination of our leadership team, which is our the Department of Health, the Statewide Sexual Assault Coalition, and us. And we meet monthly. We do all our planning together. We talk about what training to bring in based on what we hear from our communities. We talk about any issues coming up, or if there's anything going on legislatively. We just really try to stay in contact with each other. Part of our focus through this project has been to try to build more of a primary prevention team. So the way we do that is twice a year we bring in the executive directors and the prevention staff from each of the rape crisis centers. We've also identified some other partners like IHS, Valencia Shelter Services, that we're inviting to meet with us as well. And we're trying to really develop a sense of mentorship between these different communities. We just want to make them to better understand that they are a source of strength and support for each other. So we're really trying to build that. And then through this contract, we're also the liaison to the CDC Rape Prevention and Education Office. We meet with them by phone once a month with DOH,
And then we take what information we learn from them and we share it with the statewide coalition. And then the other one, the Sexual Violence Prevention Technical Assistance Project, is funded through New Mexico Department of Health with the rape prevention and education funds. I'm going to jump down to this one because you can see that they're funding us to do sexual violence technical assistance with the other 3 centers. So this funding really works in tandem really nicely so that we can do technical assistance across the state with all the centers. We're also specifically developing a statewide primary prevention strategic plan. We developed the last statewide strategic plan in 2008, and so now we're building on that and working on a new one. The other one really focused on just capacity building for primary prevention. We're really trying to do this one more broadly. So we were originally going to do 5 focus groups around the state, and then based on our advisory group that meets monthly, they talked us into doing 11 focus groups around the state with the funding 4 to 5. So we worked with all 7 rape crisis centers, which was really nice, and then they really wanted us to work specifically with some populations that are high priority populations. So we did one focus group with young males here on campus. We did one with the immigrant community down in the Las Cruces area. We did one with the LGBTQ community in Santa Fe. And then what was the other? Native American. Native American, yeah. In the last plan, we got some information from the work that's done through the Farmington Rape Crisis Center with Apache and Navajo. This time we really wanted to hear, and then we did a focus group in Dulce, Arizona. This time we wanted to hear more from some of the Pueblos, and so this one was based in Santa Fe, and we worked with Tewa Women United and Indian Health Service and worked with some of our Pueblo partners. We've got some really great information from all of these groups. It's been really exciting for me working on the first strategic plan and this one and getting the results of the focus groups, because I can really tell that there has been capacity built in the state over this time period. There's just a much better understanding of primary prevention, and there's a much better understanding of how these efforts tie into public health. Previous to this, people really saw them as very separate from public health if they were working with sexual violence. So I see that as great success, not just from us, but just all these efforts that have taken place. And then through this project, we're also doing evaluation technical assistance with all the centers. So our current status is we're going to finish that strategic plan by June. And when I say finish, I mean we're going to finish with it, and we're going to turn it over to DOH, and then they're going to review it for like 20 times. And then maybe it'll be done a couple months after that. Say what we were talking about earlier. Right. So out of the strategic planning process, we've come up with 3 goals. The first is to change norms around the acceptability of sexual violence in New Mexico. So what we're doing specifically with that is that's where we're working with the specific centers. We're really making sure that they're doing true primary prevention, that it's based on evidence, and really trying to keep them engaged and moving forward. That also speaks to bringing in male involvement and doing bystander training, because we're really trying to shift the focus, not just us, but nationwide, from prevention around victimization to doing prevention around perpetration. And then goal 2, creating safer environments through changes to organizational policies and infrastructure. This is really important because in our centers, they've been very much focused on individual behavior change, and we really want to help them broaden what they're doing to look at policy work and practices within organizations that can prevent sexual violence. And then goal 3, increasing the use of public health approach in statewide efforts. And so what we're doing in that area is we're hoping to really increase our surveillance so that we can get better data to support our work. We're really trying to work on evaluation and disseminating our results. And then, of course, we're getting a lot of information about risk and protective factors from our focus groups. We're going to continue doing our capacity building in coordination with the leadership team, the primary prevention team. And we're just now negotiating our scope of work with Department of Health. Except for the strategic plan, it's really going to be continuing our efforts around the technical assistance. One of our big projects is going to be in each funded center, we're going to do a community readiness assessment. That's going to be a lot of work. It's going to be new for us. It's going to be new for the centers. But we're really hoping that the information there can help us tailor and hone their prevention efforts in each of those communities. Any questions?
So my name is Catherine Peters, and I'm a health educator here at the Prevention Research Center. And I work on a grant from the National Institute of Health, the CEPA Award, Science Education Partnership. And our team members include Dr. Sally Davis and Dr. Shiraz Mishra as co-principal investigators, Alejandro Ortega, and so I have a slideshow and lots of pictures back here, and just kind of wanted to start out with some pictures of what we do in CEPA, and I'll explain more about our activities as we go on. But our locations are here at Cuba Middle School, which I believe you'll be traveling to tomorrow, and Liebrook Middle School, which is about 30 to 40 minutes further away down the road, and it is 100% Navajo student population. And then up in this little ranching town, Bena, New Mexico, is Coronado Middle School. So our main partners are the teachers and administration within these schools, and then also community members within the communities. Each semester we arrange several focus groups, which we call teacher think tanks. And we travel out to the schools and we ask the teachers how CEPA can best serve their students. And this was actually originally a recommendation from one of our teachers and has become one of the most important parts of our project, because it has really led us to the most feasible and effective activities that we can do in any given semester, because there is so much teacher turnover and administrative turnover in these rural areas, to be flexible to who is there and how they want to put their energy into the project. And then we also partner with UNM student groups and professors, and as well as scientists here in Albuquerque, bringing people from here out to those communities, as well as bringing students from those communities here to Albuquerque for interchange. So the overall goals and objectives of CEPA are for students to gain enthusiasm for science and math, as well as confidence, and then consider and plan for a future career in STEAM-H. So you see here, these are two Navajo young women who go to Liebrook, and in addition to the normal district-wide protocol for how science fair is run, CEPA awarded certificates for the science fair projects with distinction and significance in the field of health science and medicine. So our activities are in five areas here. We have science around us, which is the theme of our education.
Make them black.
That's okay. I'll just speak. Science around us, which are place-based educational activities that we've named the science around us. Teacher professional development, role models and mentorship, community outreach, and evaluation. So the science around us is a way to make science more accessible for these students. So the science around the students includes their own health, nutrition, activity, as well as the environment which influences those choices, as well as the natural environment that students live in, which is just amazing. You guys will get to enjoy tomorrow. Something that I've learned from CEPA we talked to a volcanologist. And that sounds like spa. Yeah. So there are geologists have classified 9 different types of volcanoes, and New Mexico has every single kind. So there's just a lot of really great public land, U.S. national parks and monuments near these students, and so taking them on field trips and hikes to these areas are one of our activities. And so here we have the Science Around Us pedometer. So we're incorporating physical activity as well as naturalist activities. So students go on hikes led by geologists or birders or archaeologists to learn about science as they go. So we see students here at the Petroglyph National Monument. So one of the things that we learned at the petroglyphs was that the ancient Puebloans who lived along the Rio Grande, they would travel and make the petroglyphs and then travel back all in one day. So that round trip is walking 6 miles within a day. So students, are learning about the history of New Mexico as well as physical activity. And then here we have students taking a field trip to, here in Albuquerque, the New Mexico Museum for Natural History and Science. And this was a traveling exhibit about fossology that you might have heard of. It is a great way to get students interested in the human body through great exhibits like this one about birds and belches. So here students are observing worms at the Cuba Community Garden last year at summer camp. One of the activities we did at summer camp. And then the top photo there is one of the students who went to summer camp with us presenting to the school board about what she learned at summer camp. So that was very brave for 6th grade. I don't think I could have done that when I was in 6th grade. So in addition to these things, we're starting up a garden. The teachers at the last focus group were really enthusiastic about the idea of incorporating gardening activities into their teaching. Career days where students from UNM and professionals from the Albuquerque area go out to the communities and talk about their careers. And so that is all I'll speak on right now. Thank you.
So I don't have slides. Breathe a sigh of relief. Just one. So the health impact assessment, those of you who've been around us for a while have heard us talk about it. You've heard Teresa talk about going to our first workshop when we had Kansas group from CDC come and teach 60 people in New Mexico how to do a health impact assessment. And you heard this morning someone, I'm trying to remember who talked about, I think it was Patty, that a health impact assessment was one of the first things that they did when they were determining the walking along for kids in the RWJ, the Kids Project. So we did a rapid HIA. And this time we were more ambitious. As Andrea and a few others in this room can tell you. And I'm sorry that Danielle is no longer here. She's on her way to Uganda for 2 years, and she last Friday was her last day. We have a large group and a very small amount of money from the Community Foundation in Santa Fe that actually came from Kellogg. And a health impact assessment is usually done in a community, particularly addressing health disparities. But if there's like an asbestos firm that wants to come in and put their building, their company next to the school, or something that's going to bring something harmful to the community, and it hasn't been used very much for looking at how how could a decision by a policymaker bring something positive to a community? So with our core research project, Viva One Step into Cuba, guess what? We were looking at public lands and why weren't they putting trails and trailheads near communities rather than seeing it as a, for example, the Continental Divide Trail going from Mexico to Canada, but not coming near the community. So I'm going to pass one around, but for the CDC visitors, you have one, but it's embargoed. Everybody, and I'm going to hawk whoever's, we can't release them because tomorrow, when we go to Cuba with our site visitors, we're going to officially present to the Forest Service our published edition that just came out on Friday. So you can see why I'm so excited about this. I will pass it around. And we looked at everything from health to economics. If we put trails, trailheads, access, remember the community guide, access to places to be physically active. If we put an access trail to the Continental Divide trail, people will use it. If it's Cuba is sitting on 550 and there are all these people going from Albuquerque to Farmington, they will stop, they will use the trail, they will buy gas, they will buy food, they will buy water, and many other things. And we've had students working on this project, Andrea, Alejandro, community volunteers, and you'll meet some of them tomorrow. And as a result, it's now ready to give to the decision makers, Santa Fe National Forest and BLM, to encourage them, and we have recommendations based on some very sound research, to decide to put the access to the trail near the town so people can use it. And so that's in a nutshell. I'll pass this around. I'm not going to spend more time because first I'm going to ask Nick to just give us a little bit about his water project. Then Linda's going to give her project. And now that Gabe's here, then we can move into that. But Nick, you want to tell us a little bit about your water project, which is a part of Viva 2? I'm just afraid you're going to leave and we won't have had to talk about it.
That's fair.
I told him he didn't have to bring slides, so.
Yeah, I'll recycle this slide. So yeah, I'm a first year medical student, so I'm just now beginning with the project. And we're looking at a couple of possible interventions for increasing drinking water consumption in the town of Cuba and the surrounding communities. And we're looking to do so both in the community and also the school level. Initially, we've identified a couple barriers as to why people aren't drinking water. We've had a couple town meetings. We did a feasibility study very informally with people in the community about, all right, why aren't people drinking water? What might work, might not work? There seems to be a lot of issues with perception and also actual drinking water quality. There's well systems, there's community systems. So people doing water catchment, a lot of the reservation is actually trucking water out. So we have a wide variety of water access issues. And then even for kids, a lot of it's perception too. People say the water tastes bad. It doesn't taste great. And so we're looking at a couple of interventions that are initiating this fall over the next year. Pairing it with a general survey, we'll have some questions about water consumption. And then we're also thinking about doing a qualitative study about perceptions and how to address some of those perceptions. So yeah, it's pretty difficult, but we're just initiating this whole kind of component of the grant.
And I want to tell our visitors this morning, you asked about, did the Alliance sort of, what did they come up with that they wanted to do? And when we were writing the proposal for this round in response to the FOA, the Alliance, members of the Alliance said, we want to do something about everybody drinking soda pop. That's all they drink. And so it went from don't drink soda pop to this make water you drink. And that was something we could do with the cuts in funding, was that we could do something, especially turning it into a medical students project. So when you say why water, people kind of frown, but there is a big movement to get people to make water their drink instead of big gulps and sodas and everything, especially in our community. So I just wanted to make that connection to this morning. So all the way through today, I've been trying to do the, make some of those connections. Linda.
Everyone do something with me. Stand up, put your chair in. We've been sitting for an hour and a half. I'm going to talk for less than 5 minutes, and I want everyone to pick out one activity to do the entire time I'm talking. And so you can be as fidgety as you want. You can do arm circles, you could stretch, you can do toe taps, from heel to toe. You could roll your neck, stretch your neck, put your hand out in front of you, pull your fingers back, just a little stretch. But the entire time, please feel free to fidget and move, and even walk around. So, the project I'm going to talk to you about is the Physical Activity Kit. PAC is our acronym, Staying on Active Path in Native Communities, a Lifespan Approach. And the entire goal of the PAC, the materials are to increase moderate to vigorous physical activity in whatever you do. If you're working in a classroom, if you're working in a wellness center, if you're working in a Head Start, if you're working with elders, anything you can do, including physical activity, dances, movement, just to get more active. So the first thing I want to acknowledge is Pathways. That little icon, this is some of Sally's early work in the 2000s. Pathways was a curricula that had physical activity and nutrition, and it was, they had a food service element, they had family activities, they had all kinds of things. We were able to use their physical activity games and movements from Pathways in order to build PAC. The other thing I want to point out is this healthy body awareness. This the primary activity that this came from was called Healthy Paths, and that was a PRC funded project in the early days in 2000, and it built into healthy body awareness. So for Pathways, we have book number 1. Book number 1, and here's a picture of all our books. We also have demonstration videos that goes with this. But book number 1 is for young people. You can do it in the classroom, and there's individual activities and group activities of young people ages 3rd grade to 5th grade. Pathways Challenge is an actual circuit where you make your pathway up Mount Pathways. It's a challenge that's used in like a over time, a 6-week program. There's 6 paths to climb the mountain. Book number 3 is Modified American Indian Games, and that's truly what it says. They took Pathways was able to take American Indian Games from all over the nation. They had individuals modify them to be safer, to include activities to keep the entire classroom. Even though they're playing a game, there's activities on the side in order to support that game. Exercise breaks and icebreakers. Those are things that you could do in a classroom. You could do in business meetings, in any type of meeting, just to get people up, mingling, to get to know each other, to share information while moving. Young children is Head Start age children. Adults and Family builds off some of the Catholic family events and dances. And older adults is a beautiful book that was created to use with elders. And the resources is book number 8. And also on the PRC's website and the Indian Health Service website, you can find the books. They're PDF. You can download them and use the materials from them. All of our materials focus on warm-up or cool-down activities with their flexibility, cardiovascular, and strength activities. So this is the diagram of the partnership, and it truly is a partnership. The Indian Health Service has been instrumental in getting this project with us started, and we put together the materials. But I think one of the most unique things about this partnership was the heads of the national programs of the National Health Promotion Disease Prevention, the head of Nutrition and Dietetics, the head of the Head Start program, and the community health representatives at the national level were our partners. They came, we sat down together, and we went through all this material and put it together. Area Office Albuquerque
Portland and Oklahoma also had their health promotion disease prevention representatives. And all of these people have been intimately involved in developing the material and also getting it disseminated. What we did after we developed it in 2007 was brought in field sites from all around the nation. They were our partners. We trained them on the materials to take it home, take it to the communities, give us feedback, tell us what we could do to fix it or to make it stronger. Then we had a summit that they came back and trained us on what they did as modification. 2009, we were invited to the Health Service headquarters, and we did a national rollout at the headquarters level. And the PRC, from the PRC office, Joanne Grumman, who is now since retired a year ago, less than a year ago, also flew to DC to be with us at that time. So what PAC is a train the trainer in a workshop model where we go in and we describe the books, we demonstrate them, and we have games, movements, and physical activities for all age groups. And then we allow the people who we train to teach back. They also, we give them time during our workshop to develop an action plan that they formulate what their goals were to implement PAC in their communities. And we just had a training just last week that as of last month, we have over 1,000 trainers from the Albuquerque area. And these are individuals that the communities invited into their community. They identify who they want there at that training. Teresa Clay and myself are usually the trainers. So we have about 30, you can see about the size groups that we have. These are individuals from their wellness center, from their Head Start program, teachers. This last training we had last week, we had 2 individuals from behavioral health. They had an in-house residential program with young men, and they were so excited to have some materials to take back that they could use in their facility. And our outcome is the feedback we get from the individuals who have gone through our training. They have told us that they've been motivated, and it also gave them confidence in going through the training to actually lead physical activities in their communities. We have, for example, one woman, she didn't feel comfortable being a teacher, but she went to bingo. And at breaks, during bingo, she gets the entire room up and moving of doing physical activity during a bingo break. And that is, she's so excited about being able to do that and feel comfortable doing that. And so this is the website right now where all the materials are with the demonstration videos. As soon as our website goes live, our new one, we'll be bringing in demonstration videos at that time. Any questions?
Workshops recommended to you through the Indian Health Service? Do they recommend communities too for the workshops?
Yes.
Okay, because I know you say you're doing the workshops throughout the next 5 years. You will be.
If we're inviting into the communities.
Okay.
The communities ask us to come in. We work with the Indian Health Service, and they have a warehouse with the materials that we are able to take in. And this is the actual equipment kit itself.
Oh,
The books are in
okay.
here too. We have information if anyone wants to know information. So, did everybody move?
Yes.
Okay, how are you feeling? What are body cues? We always ask, what are body cues? Did you get your heart rate enough to feel some body cues? What's your body telling you?
It's good to stand up.
It's good to stand up. Okay. Well, thank you all for moving with me. And next presenter.
Okay. Now, a bit of a shift to speak some about partner organizations. And I'm here to describe the New Mexico Center for the Advancement of Research, Engagement, and Science on Health Disparities, or New Mexico PRC, which is an initiative focused on eliminating health disparities and creating health equity in New Mexico and beyond. Funded by the National Institute of Minority Health Disparities. We conduct research, education, and engage in communities. Our aims are to expand research on solutions to health disparities and health equity, to increase the number of people engaged in research on health disparity solutions, and partner with communities for finding solutions to those disparities. We have 3 key principles, including the importance of that community partnership, as well as recognizing the multifactorial, multi-level nature of health disparities and targeting our interventions across those levels within the social and cultural context. And our focus is primarily on translating evidence-based intervention and community, cultural, and practice-based evidence. So we have more or less 4 key components: community engagement, research and research infrastructure, education and training, as well as environmental health for students. I've listed the key internally funded research projects here. Just very briefly, there's one on addressing the problem of serious adolescent and behavioral health, including suicide in tribal communities, enhancing screening and brief intervention for substance use disorders in primary care. Another one targeting racial and gender bias in medical student medical decision making and strategies to reduce that. One which looking at disparities in food security environment. Another one on reducing disparities and health impacts of environmental uranium and arsenic contamination of water. More recently, we've got funding for 3 new projects, increasing Latino health insurance enrollment, cancer survivorship care in rural and Hispanic women, and early childhood development and subsequent school success. Beyond those research projects, we also have had a number of other activities, an annual health disparities conference. We've heard mention about our undergraduate pipeline program for students who spend this summer in partnership with teams here to learn about the research project, particularly community research. We've carried out focused community and cultural dialogues with several communities around the state. Environmental health education, we partnered with Clinical and Translational Research Center here in their certificate and master's program, and we conducted a seminar series. We have a number of shared interests with the PRC, including the focus on priority health disparities topic. You've heard a lot about that already today. A shared interest and focus on solutions, interventions, rather than further describing the nature of the problem. We want to try to find solutions to it. And shared experience and skills in community-based work. You've heard about the PRC sponsoring or housing undergraduate pipeline students in our program. They also assisted us about 1.5 years ago with a conference that we held to identify some specific feasible steps to advance equity in 3 targeted conditions. And you heard a little bit, you're going to hear a little more about this planned summit conference between our center and the PRC and the RWJ Center. Thank you.
I don't mind if you get up and do jumping jacks. Thank you for giving me an opportunity to talk a little bit about our center. We are funded by the Robert Wood Johnson Foundation, and our primary focus is to fill a particular void in kind of the whole workforce dynamic, where I think for the most part, when we think about shortages in workforce, we think about healthcare delivery. Ours is very specifically focused on another really important aspect of the workforce, and that's policy development. So thinking about training researchers or policy experts in the social sciences that come out with PhDs into training in racial and ethnic health disparities. That's our primary and core mission. We've been at this since 2007, and it took us a while to figure out exactly how to train a political scientist like myself and also influence health policy. But I think we've cracked that egg. I think our evidence suggests from last year, we had 5 graduates, all of color. Almost all of our students are of color, and increasingly females of color. And we placed one at the University of Michigan Med School on a postdoc, and the other one at Stanford. So I think we're really starting to show some success on that dynamic. And we're really pulling together a pool of very talented from the recruitment standpoint and the resources, as I'll show you in a second, that they have access to, but a new perspective to policy discussions and research. And I think RWJ's primary thought process was, if you bring in more diverse researchers that have this very nuanced training, it's got to change policy outcomes because it's a new voice at the table. That's in essence what we're about. So what exactly do we do or provide for our fellows? You see that we're inherently interdisciplinary. We have fellows from econ, political science, sociology, psychology, anthropology, and we added our first this year from the College of Education. So inherently interdisciplinary, and it's amazing when you get all those folks together talking about any healthcare issue from that range of disciplines. I think the proof is really in the pudding about what you see when you are there in the room with them. We have a very comprehensive fellowship experience with a whole lot of infrastructure around them to make sure they're successful. We have full in-house statistical and writing support. Statistical support is by far, in terms of our evaluation, the most important piece of the puzzle. Again, we're dealing with almost exclusively PhD students of color, and that's by far the biggest hurdle is getting through their stat sequences, especially in economics and political science. So we also have really formulated with a lot of faculty, a community of scholars and support network around those folks. I'll say that we are doing two things very well recently. One is connecting better with the medical school here at UNM, and that's really related to the partnership that Rob already alluded to, getting more of our students working on projects on this side of campus. The last 2 years, you're literally starting to see students create their whole dissertation data out of internships that they're doing over here. And I think that's a very positive outcome. The other is, I think this sector has become a hub in social sciences at UNM. An indicator of that is 2 years ago, we had the greatest hiring surge in history at UNM in social sciences, and almost 50% of those folks were health-oriented scholars across about 15 different disciplines. They were even finding historians that had a focus on medical or healthcare issues. So I think that's really also a hub around just the institution itself embracing this mission. And we obviously try to connect faculty as mentors and through similar ranges of infrastructure to the same enterprise to not only train PhD students, but obviously to engage faculty in that work. Our on-the-job training model, we really focus on a lot of additional skill sets beyond what you would get in a traditionary, disciplinary level training as an economist or sociologist. So we do everything from media training. I do a lot of media work myself, so I'll take all of our fellows over here to one of the local studios. We tape them in terms of doing interviews around their research so they can analyze that. We have a lot of media experts come out here to UNM to give our folks really hands-on training and how to work with the media so they're effective in getting their research really, hopefully, at the highest levels of the media that obviously influence policy outcomes. A lot of health policy, curriculum, and policy internships. So these days, we require all of our folks to spend at least a summer or a semester engaged in applied policy work. Whether that's in DC, whether that's here in New Mexico, all of them are required at some point to work with an agency doing on-the-ground policy work, so that it's not just training from an academic perspective, but hands-on. Access to national leaders in health policy research. We have a pretty impressive national advisory board that includes the likes of like Thomas Luis, those kind of caliber of folks that engage one-on-one with our fellows. We host a lot of major events. Last year, we were fortunate to convene the biannual Congressional Health Disparity Summit. That's out of the Tri-Caucus in Congress. We got to hold that here in Albuquerque out of our shop. So that gave our fellows an opportunity to interface not only with leading experts, but also members of Congress who are engaged primarily in mental health. We do policy brief and blog writing training. All of our folks are required before they graduate to actually post a blog to a high-level outlet, whether it's through RWJ or through other mechanisms. I'll talk a little bit about that in the research that I showcase. And more recently, we're doing a lot of job market preparation. I put together a formal course that I'll be offering in a couple of weeks. And the cool thing about this class is it's not just about placement in academia. We have people coming from federal healthcare industry, from Urban Institute this summer coming out. So they get an opportunity to see not just how to frame yourself for academia, but if you're interested in doing applied policy work as a PhD, how do you get into those networks? How do you interview for those positions? And this is paying off. I have a student now interviewing. She'll be just finished up her PhD. She's interviewing for basically a job just like mine at the University of Washington, running a center. So I think the pedigree of the folks that we're putting out there is immediately having an impact on outcomes. I'll give you one quick example of some of the research that our center is comprising or really is focused on. This one is a survey really on the intersection of immigration and health policy for the Latino population. Our focus tends to be Latino and Native American. There's a sister program at Meharry Medical School that's African American focused, so we interface a lot with that center. This survey was released in late March, early April. Got a ton of national media attention. We wrote 2 posts for the Huffington Post. We did a lot of TV work for MSNBC and one CNN spot. So it gave our fellows an opportunity to really not just learn about doing media work, but physically do it. And this was based on a training grant from RWJF to really give our fellows in this context a hands-on experience in survey methodology. So over the course of a year, we had about 11 PhD students all working on this team, developing the instrument, the sampling approach, the whole shebang in terms of start to finish on a research project. As the PI of that, an amazing project of working with, I think, 15 or 16 different scholars. I was glad when it was done. Overall, we had about 1,405 overall respondents. I'm only going to show you the telephone sample. Today, we're still working out some of the weighting on the web sample. This was conducted by Latino Decisions, where I'm a director of research for that firm, so we do a lot of work with those folks. You see, it was a pretty large survey, 22 minutes average interview, 27 minutes in Spanish. So extremely in-depth. I'm only going to show you some of the high-level findings, but there's a lot of other information here. It's available on our website if folks are interested in seeing the full slide deck. One of the things we really wanted to focus on here was, has the ACA actually worked for Latinos? So when you see overall, the percentage of insured, 82%, without some context, you might not have an understanding, is that good, bad, or ugly? We did a very similar survey almost a year ago to the date of when this was fielded, and this jumped 11% in the positive direction in just 1 year. So in one element, the ACA definitely is working in terms of increasing Latinos' access to health insurance. But you see on the breakdown, there's some variation based on income and nativity being the biggest sources of variation for Latinos. Not so positive when you ask individuals, okay, did you go without insurance at any point during the last year? You see partial coverage still remaining a big issue, even for those folks that utilized the exchanges or marketplaces to become insured. You see variation, again, on income and nativity being some of the biggest factors that separate what folks are going at least part of the year without access to insurance. One of the findings that I think got a lot of media attention, especially when we did some more rigorous analysis around this, really basic information or outreach question about the marketplace and exchanges. Basically, have you heard a great deal about it or heard nothing at all? The take-home finding, I think, from this is, if you see overall 1 in 4 Latinos nationally says they didn't hear anything, literally anything whatsoever about the exchanges and marketplaces. So if you weren't following this in the news, there was a ton of deliberation about whether or not, particularly in Spanish, if the tools were working effectively. If folks don't remember, they were delayed a month from when they were supposed to be unveiled. A lot of conversation about whether or not the Spanish translation was effective or on point. Other questions that I don't have time to show you today really dig into that and show, for the most part, Spanish speakers were saying, I didn't have access to it because it wasn't available when I was ready to go into the exchange. And if so, the translation was impossible to understand. So I think that confirms what a lot of people suspected what was going on. A couple of things on projected impact. So this is, attitudinal about perceptions. A couple of these that I'll highlight is, if you ask people, do you think, through this reform effort, the ACA, do you think the healthcare costs for you and your family will get better, worse, or stay about the same? You see the trajectory here. There's as many, if not more, folks who think it's actually going to get worse in terms of cost than it's going to get better. And a lot of the focus groups that we did, particularly in Spanish, the take-home phrase we heard over and over again was, I thought this was supposed to be the Affordable Care Act. Where's the affordability? The sticker shock associated with folks that actually went through the exchange is pretty extreme. A little bit better when we talk about other elements like quality. You see there's a better trajectory there. Folks actually perceive that the quality is going to improve. It's really consistently been over the time we've been surveying this since 2008. Cost for Latinos has been the primary issue, thinking about health insurance. Finally, when we ask folks directly, did you try to enroll or buy insurance for your state or federal health exchange program? Only 22% of Latinos nationally attempted to engage in the exchange. The good news is the moral category for why did you not was, I'm already insured and I'm happy. Right, so that's a positive take-home message. Not so positive, though, for that 22% that actually tried to engage or enroll, we asked a lot of questions. Were you able to enroll without problems? You see about a third of the sample indicated yes. But a lot of folks said, I had problems, and a large, 2 out of every 10 said, I had so many problems that prevented me from enrolling. So clearly, there needs to be more work, particularly outreach effort, directed specifically to the Latino population, not just in Spanish, but in English as well. Other question in terms of citizenship status, we spent a lot of time thinking about this notion of living in shadows, obviously looking at how immigration is impacting health outcomes for Latinos. This one generated a ton of media attention. Pretty straightforward question. Have you avoided any of the following activities because of your citizenship status? These are not just non-citizens. This is an overall national sample. As you see it, 1 of 10, almost 10%, visiting a doctor or clinic and saying, I skipped an appointment because I'm worried about being asked about my citizenship status, even all the way to talking to police or reporting a crime, 13%. That includes actually a higher percentage of U.S. citizen Latinos than the non-citizens that are dating, and they avoid that activity. So that's just an example of the kind of work we do. I'll leave you with maybe one of the biggest in terms of our research that's ongoing with this project, looking at individuals that lived in states with punitive immigration laws and that they perceive those laws are negative towards immigrants. Those folks have worse health outcomes across diabetes, BMI, self-reported health, about 4 or 5 different indicators of health outcomes. So we really are seeing this unfortunate intersection between immigration policy and health outcomes. Thank you. I hope that was informative.
Thank you.
Before Alberta starts, and then we're going to have Alberta, and we're going to have Dr. Wong, but I just want to bring the last 2 presentations together with the PRC. And Colleen may remember that we tried very diligently to get them to come on their site visit in August instead of now, because Rob Williams, who is, we didn't mention this, but on faculty in community and family medicine, and Gabe, who is on faculty in political science on the other campus, their centers and the PRC have been meeting weekly since Christmas to put together a summit for the 3 of our centers to get to know each other better, to cross-reference and cross-work, to do some work together, because we have these silos at the university, and you heard what Gabe was talking about, and you heard what Rob talked about, and you know what we do, and if you don't see the connections, then, you know, I'm not sure how to make that connection for you, but because we do different sides of the same picture, we're very excited, at least I am, about this summit, and it'll be for our internal, for our 3 centers, all of our staff and faculty to get together and share our work. And we're calling it right now, Addressing Health Equity Through Research, Policy, and Systems Change. And I'm going to just read you very quickly a tentative agenda for that summit and the national agenda for a healthy nation and what it means for New Mexico. Invited Tom Udall, Senator Tom Udall, Ben Ray Lujan, Michelle Lujan Grisham, Martin Heinrich, and I'm not sure of the status on inviting Steve Pierce yet, but
He's been invited. He hasn't confirmed.
okay. And so to have the national agenda, this is we purposefully put it August 15th to have it during their recess. So they're home, and we want them to come and talk to us about. So we know that, for example, Michelle Lujan Grisham, her thing is addressing hunger. And we want to hear from her. And we want her to hear from us about what researchers and policy researchers and disparity researchers and prevention researchers are doing in New Mexico to address all those things that you heard Andrea talk about this morning. That's what we're here for. Our 3 centers are all dedicated to addressing those so that we're not the first in the awful list, or the second in the awful list, or the last in the good list. And then we invited the Secretary of the Department of Health to talk about the state agenda for a healthy New Mexico. And then the 3 of us will talk about our centers, and then our teams will do some of the same things that they did today. And then we will all do, I think we're calling it speed dating research tables. And then in 3 months, we're going to get together and see what came out of that. Are we really collaborating across these 3 centers? And so I do appreciate Rob, you and Gabe both. And now we'll turn it over. I think we have, is it Berto or is it David? Berto, you want to do yours, and then David.
So I'm Alberta Kong. I'm from the Department of Pediatrics in the Division of Adolescent Medicine, and I'm a pediatrician with the subboard in adolescent medicine. I'm actually housed here in the Prevention Resource Center, and that started when I received one of the first NIH KL2 Career Training Awards in research, partly to train physicians like myself in doing translational research. And that's through the Clinical and Translational Science Center. And my mentor is Dr. Sally Davis. And therefore, I've been here ever since 2007, 6, 7, around there somewhere. So
I've given you a little bit background because my work actually started when I received my KL2 award, and I've been able to get that funded all the way through to an R01 process. So, and that's really been the help of the Prevention Research Center. So Action Path is the study's title. It's Adolescents Committed to Improvement of Nutrition and Physical Activity. So that's our long title, but we condense it to Action Path. And the funder is NIH, from National Heart, Lung, Blood Institute. We have partnered with the Albuquerque Public Schools, the Gadsden Independent School District, Las Cruces Public Schools, the UNM School-Based Health Center Program, and also the Community Foundation of Southern New Mexico, who also runs school-based health centers down south. And our location, we're in 8 school-based health centers, 4 of which are in the Bernalillo County, and 4 are in the Doña Ana counties. And so first started, I was fortunate to receive an R21 during my KL2 training. And so the first phase of it was creating the intervention. We wanted to create an intervention that was deliverable through a school-based health center, specifically in the high schools where it's easily accessible to adolescents. Because we know how often they come into primary care, right? It's just not priority for them. And so they're much more accessible in school. So the first phase, we used community-based participatory research principles. And we worked with overweight teens and their parents and school-based health providers to actually develop the intervention. We wanted to make it usable, and we wanted to make it feasible that it was actually deliverable by the school-based health centers, because they are very busy clinicians. And then the phase 2 was, after the development of the intervention, we wanted to pilot test it. You know, would kids be acceptable to coming to the school-based health center for things like weight management? And we created our little toolkit, which I think you were maybe able to see. That has changed a little bit. It was very pretty, but it wasn't as usable. And so we created now more of a toolkit and a provider binder so that they can get their information but all the handouts that they would give to the kids would actually be from the box itself. And we were fortunate we were able to pilot this in 2 groups, one in each high school. We decided to do a quasi-experimental design on this part because we wanted to limit the contamination that may happen between the intervention group and the control or comparison condition. And so we had a small sample size, 28, and that completed, that's 90% of the completers in the intervention group, and then 23 from the control group, and that was 79% completion. And we did have a decrease in their BMI percentiles from the intervention group. And because the control group continued to gain weight, which is common in the adolescent period, and that's why there's such a high risk that if you are an overweight or obese adolescent, that you continue to be an overweight obese adult. And so we were able to show some statistical significance, and then we're fortunate to then apply for an R01 and receive the funding. And currently, we're in year 2 of that process. And so we're working now again with 8 high schools in New Mexico that have school-based health centers. We have actually an intervention, a prevention arm, and then also a treatment arm. And so the 4 schools get randomized to the intervention condition, and then 4 to a control condition. And so for a prevention arm, the kids who get the intervention get an annual BMI sort of result. We actually measure them. We have, and then we send the information back to their parents, sort of like like in Arkansas where they're doing a BMI report card, where they're sending that information back to the parents, and then the parents decide if they want to continue on with the school-based health center for management, or they can take them to their child to the primary care site to have management if needed. The comparison condition in the prevention arm, get the results, but the intervention site actually get a discussion. I didn't explain that very clearly. The intervention groups, after the kids get the result, they get a motivational interviewing discussion with the school-based health center, and that's the intervention arm. then those kids who are overweight, obese, so they're greater than the 85th percentile, and that's according to standard of care in medicine, that they would go on to then get blood tested for things like lipids and glucose, screenings for type 2 diabetes. And in the intervention condition, those students also get results sent to their parents, but they get 8 motivational interviewing sessions per year for 2 years. So they get 16 sessions altogether. So they get followed up and seen about once a month in the school-based health center. In the comparison group, again, they do not get the motivational interviewing sessions. They get the report card that goes to the parents. But the kids are, open to coming into the school-based health center if they choose to do that. Or they get followed up by their primary care. Or they may not do any of that. And so we have a little bit of results to share with you. We're still not completely done with recruitment. We have 552 students at this point, and you can see, and again, and I should mention that we're recruiting mainly 9th and 10th grade students so that we can follow them. So 9th graders get followed annually until they reach their 11th grade, and 10th graders get followed annually until they reach their 12th grade. And so that's why we do have more in the younger population from 13 to 16 years of age. You can see that majority of the students are Hispanic, 77%, and as in comparison with primary care, we have more females than males in the group. And these are just a little bit, again, just what we're seeing. Most of the students are in the normal weight range. We do have some that are in underweight, and then you can see overweight and obese, some in those categories. And then this is just a little bit about the cardiometabolic risk that we're looking for. So you can see in the obese group, there's around 25% who already meet the criteria for metabolic syndrome, and that would include having an elevated one of 3 things. They have to have 3 components out of 5, so they can have a high blood pressure or a low HDL, low in your good cholesterol, the HDL is what that is, or a high fasting glucose, high triglyceride, or a high waist. So meeting 3 out of 5 of those components sets you up for metabolic syndrome. And you can see that the obese kids obviously have more risk for that. And then what we usually see that goes first in adolescence is a derangement in lipids. And that's what you can see with the higher prevalence in low HDL. That means they have low good cholesterol, and then also the triglycerides. And then we actually maintain our glucose pretty well in terms of getting type 2 diabetes. And you can see that there's a small proportion, but still significant, I think, and it's scary that these kids already have pre-diabetes. We actually didn't find anyone with type 2 diabetes, which is really great news, but we do have, close to like 17% of the overweight obese kids do have pre-diabetes. And then we didn't have much of the hypertension, which we defined it here as greater than or equal to 95th percentile systolic blood pressure. So I just wanted to show you our team. We have many investigators. Sally's included on this. Sarah Felsen-Ewing is our motivational interviewing expert. Mary Ramos used to be the medical director for Department of Health, Adolescent and School Health. Dr. Skipper is our biostatistician. And Elizabeth Yates-Jimenez is our nutritional epidemiologist. And we have many significant contributors from the Las Cruces area and also in the PRC here itself.
Thank you.
Oh, David, you're up finally.
Yeah.
Dr. Wong is on our advisory council, the Big CAC, as we call it. But also, we have a lot of common interests and also some common relationship because he also has a relationship with CDC. And I'm going to turn it over to you, David.
Sure. I don't have any slides at all. So Thanks for inviting me. I wanted to just spend a little bit of time talking about Park Service and how it can be a great partner for a lot of health projects. I've been at the Park Service now for 9 years, and if you had told me in medical school that one day I'd be working for them as a pediatrician, I would have looked at you like you had 3 heads. I didn't even know this existed. But we actually have 43 public health service officers that are detailed to the National Park Service. So we actually have a nice crew that can work on different things. Just 3 different areas, kind of nice initiatives that are triangulating that make us kind of a good time to partner. First of all, we have a program called Healthy Parks, Healthy People. It's one of our directors' initiatives. It's been around since 2011. The basic concept of all the things we're talking about here, access to nature, improved nutrition, having parks, and particularly national parks, as models for healthy living. And so we have 407 parks in every state and about 285 million visitors a year. So we're trying to motivate all these different park units to participate and develop what we call HP, Healthy Parks, Healthy People programs. And so this is something that, I think any state that you work in, including New Mexico, where we have like over 10 different national park service units, there's lots of possibilities. Another thing that's really interesting is our centennial that's coming up next year. So the 100th anniversary of the National Park Service is in 2016. And with that, we have a lot of extra funding. We have a lot of projects that we want to promote to the public. And we'll get a lot of visibility because of our 100th anniversary. So there are some specific projects that I'm working on with different aspects of health that we hope to eventually get as kind of signature centennial projects. And then finally, we had an MOU, which is here, if you guys want to pick it up later. It's signed between the CDC and the National Park Service in 2012, and basically to highlight the role of health with the National Park Service and to improve collaboration across Department of HHS and Department of Interior, where our agency sits. And from this MOU, this was vetted by all the different center directors at CDC. I used to be at CDC way back when. And so this got a lot of kind of visibility just at a very high level. We met with all the deputy directors to talk about this MOU. And I always like to use it as a way, as a permission, for different CDC personnel that may not be familiar. Well, why would we want to work with the Park Service? Well, here, this is an MOU, the director read and sign this. He actually is encouraging you guys to work with us. So last week, actually, I was at Rocky Mountain National Park, and we were piloting a tabletop exercise on plague. And it was basically a tool to improve how park managers can understand about public health emergencies that they might face. We actually had people come from CDC Atlanta, CDC Fort Collins, state and local health departments to all participate, because when there isn't a large infectious disease in a park, you work with all these different agencies, and it's not groups that park managers generally work with. So that's just one example. Now, as far as specific programs that might be more germane to your work, I just want to mention 2 things, and I want to keep this short. One thing that we've done in the past, and we're considering doing some more again in the future, is what we call Mather hikes. And so Stephen Mather was our very first director in 1916. And before the Park Service was created, he needed to get support and interest in his work. Why would we want to create an agency to protect federal lands? That was a very foreign concept back then. And so he created these hikes where he would take journalists and politicians and influential opinion leaders and take them to Yosemite and Sequoia and take them on backcountry hikes for up to a week. And by the time they left, they were sold. They were like, okay, we understand what this Park Service is about. And so that was really important to getting support for creation of this agency. And so 5 years ago, we created what we call modern day Mather hikes. And the idea was to take a park in a community and get local community leaders in health, in healthcare, and in health insurance, land managers, schools, whoever was interested to come to a park. And interprofessional, just as Sally was talking about with the different centers here. And we funded 8 parks across the country. We only gave them $500, so very symbolic, token kind of funding. But we got a lot of interest. And one of the parks that did a Mather hike in 2011 was Petroglyph National Monument in West Albuquerque. And it was held at one of the open space areas. I wasn't able to attend myself. But again, it was just a start to bring people together, generate ideas, brainstorm, and then we haven't had specific projects that came from that. But yeah, I think these kinds of things you kind of have to nurture, kind of feed that monster, so to speak, so that we can get projects off the ground. Other parks have been successful from after the Mather hikes in developing some seed projects. So we're excited, and hopefully we will continue that kind of work. And then the other thing I just want to mention is another big thing in the parks is what's called park prescriptions. And you guys maybe have heard about this, where physicians write prescriptions to patients about not just medicine, but taking hikes and walking in parks in their community. And we have about 6 or 7 national parks that are participating, including Golden Gate in San Francisco. We have Rock Creek Park in DC, Indiana Dunes in outside of Chicago. It's just popping up all over the place. And one of them that started even before we started doing it in national parks is here in Albuquerque. It's called Prescription Trails. And that program has been started by Charlotte Ladd, who was with the New Mexico Diabetes Coalition. Coalition get the name for agency. But anyway, we have lots of these different park prescription programs now. And we are starting to work with CDC. I'm not sure which division. It's not me personally working on it, but trying to evaluate it, these different programs in terms of how effective they are. Just a lot of the work that you guys are doing, you want to make sure that what you're doing has some impact. And so our director is particularly interested in park prescriptions, and so I know that that's something that if you're interested, I think there's some opportunity there to work on. And there's lots of other projects. I think I'll just stop there.
Okay, and David is also on our expert panel for Viva 2, so we will make some of his knowledge available to some of our communities. So we're going to let you have a chance to look at the displays, get some more water, pick up one of David's
I want to thank your whole team for the presentation, because it's a really nice comprehensive look at your portfolio. And we talk just about the PRC program, we do not always get that sense of your full portfolio and how it intersects with your other work. So this was a really nice presentation, and I do want to thank everyone for their time, taking that time to explain it to us. It's very helpful.
And thank you.
Yeah, thank you for listening.
When we were making
I'm wondering if your PRC complete.
Don't ask it. So I want to say one last thing. I kept talking about Andrea's contributions to our health impact assessment, but Renee edited it at least 4 times, I think, and Felipe worked on the layout and getting it printed so nicely on time. So if you see a typo, don't say anything. And I will say that we also got it done. Last Friday was Danielle's last day. It was the last day of our grant, and we got it done on time. So now our big work is laid out, and that's sharing it with Forest Service and BLM, like I said, to make decisions. But I wanted to make sure I recognize them for their work as well. And we always appreciate David, and he always brings like great ideas, and the idea of partnering with the parks. We also, we're having in Cuba National Trails Day. I'll put in a plug for that. That's a nationwide for trails. It's an organization, and we're celebrating with birding hikes and hikes on partnering with Navajo, Just Move It, and they're going to be coming into town and a lot of things. And then last year, you may remember that we did the Walk Off the War, where veterans hiked the Continental Divide Trail from one end to the other. And this year, the veterans, the post, the post of the VFW, they took it up and they're going to do it. So they'll host when they come through town, through Cuba. And Cuba, after that hike last year, was designated as a Continental Divide trail. So gateway community. So all kind of related to that, being outdoors, using public lands, being with families. Buy your Budweiser to support the national parks. I'm just kidding. So, yeah, that is for real, but should have brought it up here, but I couldn't help myself. Addie's sitting there egging me on.
No, it's my fault.
So anyway, take a look. Catherine, also, I just, when David was talking about petroglyphs, we also met the biologist at petroglyphs, and he said, I want to go talk to kids in the community. And he came out for Careers Day, and he's an expert on millipedes and centipedes, and he actually named one. And so he came and he brought his sample jars of millipedes and centipedes and talked to the kids at Liebrook, and he's a native man, and so this was the kind of thing